All right. So far we have talked our way through the first kind of half of the drugs. We spent a lot of time talking about antiplatelets, and then we jumped a little bit into the anticoagulants, specifically when we talked about the coagulation cascade. We finished up talking about how heparin, which is a natural molecule that exists in your body, what it does is it works with antithrombin 3 to work on factor 10, factor 2, and inhibit those factors, as well as activating TPA, tissue plasminogen activator. And that helps break down the fibrin that is present in the clot. So heparin has two different functions. As we kind of developed other synthetic versions of heparin, we get things like low molecular weight heparin, which is only working on factor 10. And we have things like fondaparinux, which is a synthetic version of heparin, which is indirectly working on factor 10 as well. So with that in mind, we are going to finish up talking about the rest of the anticoagulants, and then we're going to quickly jump into the thrombolytics, and then we will kind of finish up from there. So when we talk about the anticoagulants, so far we've talked about a lot of drugs that are going to be used in a hospital setting, especially enoxaparin, fondaparinux. They've sort of found their way into more of an ambulatory care setting, especially for bridging therapy. But we really see them when we have someone in deep need of preventing clotting. So when we look at the factor, the next group of drugs that we have, the factor 10A inhibitors. The first drug that goes into this category is fondaparinux, right? And we talked about that yesterday, where fondaparinux indirectly works on factor 10, directly works on antithrombin 3. And so what it's doing is it a factor 10A inhibitor? Yes, it is. What's important to know about fondaparinux is that it's sub-Q only. So if we want to have a good outpatient drug, then we're going to use our DOACs, our direct oral anticoagulants. So this would be our apixabans, edoxaban, and rivaroxaban. And the usefulness of these is that they're oral. That's really what they are used in, right? So whereas fondaparinux is working on 10A and antithrombin 3, the DOACs are working on 10A only. They have no role in antithrombin 3. So that's kind of the difference, the major differences between them. That being said, what's important to know is that fondaparinux is okay in pregnancy. So if you need to give a drug for pregnancy, fondaparinux is one of those that's okay. The other one I think is heparin, if I remember correctly. You cannot give a DOAC in pregnancy. They cross the placental barrier and they would cause the baby to bleed to death. Not good. The next kind of group that we're going to look at is the factor 2A inhibitors. So again, these are just a collection of drugs that are slowly working their way through all the different important clotting factors. So instead of hitting multiple ones like heparin does, we are using the drug dabigatran. Dabigatran is oral, but it cannot be used in pregnancy. And what's important to know about dabigatran is that it does have a reversal agent called idarucizumab. So let's say that someone is taking dabigatran, they're at risk of a stroke. We put them on dabigatran, and then all of a sudden they get hit by a car, and now they have to go into surgery. Well, we can give idarucizumab in order to reverse the dabigatran and prevent the complications from them having this anticoagulant in their body. So dabigatran kind of has its role there. The I should also mention that apixaban and rivaroxaban have a reversal agent as well. It's called adexanet. So same sort of situation. If someone is on Eliquis and then all of a sudden they have to go into surgery, we can breaks out. Actually, it's andexanet. We can break out the reversal agent and kind of treat them beforehand. All right. So let's talk about the most complicated one, which is warfarin. Warfarin is a vitamin K dependent antagonist. Specifically, what it's doing is that it's working on the enzyme that is enabling for certain coagulation factors to be synthesized. And so what we call these is the SNOT factors. So warfarin works on the SNOT factors, which is oh god, 7, 9, 2, and 8, I think is what. Am I crazy? No. 7, 9, 2, and 10. Oh, right. 2 and 10. There we go. What these are coag factors that require vitamin K to be synthesized. So what warfarin does is that it comes in and it prevents these vitamin K dependent factors from being created. In addition to these, it also works on other kind of procoagulation. Well, we're not really going to talk about it actually because he didn't go over it. What's important to know about warfarin is that warfarin has a lag time. And what's important to note is that we have to look at the half-life of the different factors in the body. So if we look, we have factor 2, which has a half-life of about 60 hours. We have factor 7, which has a half-life of 4 to 6 hours. Factor 9, which is about 24 hours. And then factor 10, which is 48 to 72 hours. What this means is that if you were to give someone warfarin, we can't measure the full effect of the warfarin until after all of these vitamin K dependent factors are gone in the body, right? Because if warfarin is preventing these SNOT factors from being created, then we have to look at their levels in the body. So what do I mean by that? What I mean is that if you gave someone warfarin on day 1 and then measured their INR the next day, you would see that it hasn't moved at all. And the reason for that is that after about a day, you've only gotten rid of 2 of the factors. You still have factor 2 and factor 10 hanging around. So maybe you increase the dose. You come back in 3 days, and now you've gotten rid of factor 10, but we still have factor 2. And so you increase the dose again. And so now the person is at high risk of bleeding. So warfarin has a lag time in order for us to see when its maximal amount of time is. So what we can say is that the onset of warfarin's activity. Yes, sorry, I didn't see your message. 2A means activated. Yes. The onset of warfarin action is about it's about 24 hours. What that is dependent on is factor 7. The reason is because we take 3 to 5 half-lives, which I should really write it like this. (18 to 24 hours). And the reason is because we always count by 3 to 5 half-lives. So let's say that someone has a half-life of 6 hours. So 3 half-lives would be 18 hours, and 5 half-lives would be 30 hours. And so we find that somewhere in between that, all of your factor 7 is gone. And that's where we know that warfarin, you have started your protection against clotting. So after a full day, we can say that you are starting to be protected. In terms of peak warfarin action, so where we know that you are completely anticoagulated, we don't have to worry about you. That's going to depend on factor 2. So, and really where this is coming from is factor 2. So 3 half-lives would be about 180 hours, and 5 half-lives would be about, what would that be, 300 hours? So what that means is that after about 3 to 7 days, we start to see the peak effects of warfarin. Some people, it's as short as 3 days. For most, it's about a week. This is a really, really important idea to kind of wrap your head around, because it means that how quickly can you change someone's warfarin dose? Not very quickly, right? Because only after about 7 days do we start to see if the warfarin is working or not. So what ends up happening is that we end up bridging people all the time. So while we're waiting for the warfarin to start working, we might put someone on on enoxaparin, in order for it to uh, have some protection while we're waiting for the warfarin to work. That's called bridging. Does that make sense? Any questions about that? All right. There are some big things to consider with warfarin. It's an old drug. It's very effective, but it's kind of a dirty drug in a way. The first is that it has a narrow therapeutic index. And this is the specific thing to remember about warfarin, is that small changes in the dose of warfarin can lead to major changes in the INR, or in the clotting ability of the person. So you have to be really, really, really careful with someone who is on warfarin. You can't change their warfarin dose very quickly. The other thing that we have to consider is lots of drug-drug interactions, specifically when we look at 2C9 and 2C19. Actually, you know what? We should do it like this. Well, we can leave that in there because that's still important. So let's look at the different interactions depending on what kind of effect it will have. So effects that will decrease the anticoagulant effect of warfarin are CYP inducers, specifically the drugs rifampin, carbamazepine, and our good old friend St. John's wort, as well as tons and tons and tons of stuff that we see in everyday life, like ginger and licorice, right? Those also can induce cytochrome P450s, and so we see, a decrease in the anticoagulant effect. The other thing that we can see is a increase in vitamin K in the diet. Warfarin works by preventing vitamin K from being utilized to make the SNOT factors. These would decrease warfarin blood levels, but having more vitamin K in your diet wouldn't necessarily decrease the warfarin blood level. So essentially what this is talking about is that someone, they go to the doctor, they go to the hospital because they have a heart attack, they're put on warfarin, and then they say, I am going to, turn my diet around. I'm going to start eating spinach every day. Well, spinach is really, really, really high in vitamin K, and that's going to work against the warfarin that they're taking. So what's the important counseling point that you should tell people who are on warfarin is that you should keep your leafy green diet the same. So what that means is that if someone has a salad every Wednesday, they should continue to have a salad every Wednesday. They shouldn't start ingesting or taking out vitamin K from their diet without telling their warfarin nurse, the nurse that's in charge of dosing usually. The last one that's going to decrease anticoagulant effect of warfarin is a decrease in gastric acid, which of course would be things like proton pump inhibitors, right? And what these are doing is that they decrease the uptake of warfarin. Warfarin needs an acidic environment in order to be absorbed. And so taking your warfarin at the same time as your omeprazole is going to fuck that up. In terms of increasing the anticoagulant effect, right? So decreasing the anticoagulant effect is going to put someone at risk of clotting, whereas increasing that effect is going to put them at case of severe bleeding. And so this would be tons of CYP inhibitors, tons and tons and tons of CYP inhibitors. You have things like antidepressants. You have grapefruit, which I should put that up here, 3A4. That's the other one. You have PPIs. Tons and tons and tons of stuff. The other one that's going to increase the anticoagulant effect is acetaminophen. What acetaminophen does is it interrupts the vitamin K cycle. And so it's like you are having an additional baby warfarin working on the same site of action that warfarin is working on. So someone who is on warfarin shouldn't really gravitate towards Tylenol as their preferred, anti-fever, anti-pain. They should go more towards something like an NSAID. But even then, it's not a really great choice because, it puts them at risk of bleeding and gastric ulcers, and it's just a whole big mess. Now, you could argue that as long as they're taking it, sparingly, or that they're using low doses, it can be fine, which, I could probably get behind. Next one is plasma protein binders. So warfarin is highly protein bound. And so anything that's going to displace warfarin from plasma protein is going to make more free warfarin available. It's going to increase the action of warfarin. And then finally, the last one is gut flora damage. The bacteria in our gut is responsible for activating vitamin K, making it bioavailable for us in our diet. So if the bacteria in your gut are damaged, say you have severe diarrhea for a few days, then the normal amount of vitamin K that you produce throughout the week is going to be disrupted. And so less vitamin K that your gut is creating means that warfarin isn't going to be competing as much, and it means that it's going to be working much, much better. So someone who has severe diarrhea for a few days on warfarin might be at risk of bleeding. The other thing to note about this is what kinds of drugs affect gut flora. Do you have an idea? Antibiotics, exactly. Antibiotics, which is this what ABX stands for, they can kill off good bacteria in the gut, right? So if someone is on even a short course of antibiotics that, maybe it doesn't directly affect warfarin through a CYP enzyme, but if it does affect the gut flora, then you're going to be changing the amount of vitamin K. Now, again, you might be thinking, well, shouldn't this be a really, really, really small change in vitamin K? And it is. But this is the big thing about warfarin. It has a very, very narrow therapeutic index, right? It doesn't take a lot to fuck with warfarin. So even that small change in the amount of vitamin K that the gut bacteria is producing is enough to disrupt what warfarin is capable of doing. And so that might mean that, someone gets, they get a little sick. And so they have some diarrhea over the weekend. And then all of a sudden they're having nosebleeds and, tons and tons of bad effects, stuff like that, which is not good. I was able to work with the Coumadin clinic, and there's a lot of work that goes into dosing warfarin. It's a scary drug. It really is. And the thing is that it's an old drug, and we tend not to, we tend to say like, oh, people aren't on old drugs anymore. They're on warfarin. There are plenty of people on warfarin, and they're all old, and they all have huge med lists. All right. Our last drugs that we're going to look at are the thrombolytics, which are all of the drugs that fit at the bottom of this diagram here. And specifically, the thrombolytics are all about increasing the action of plasmin. So they all increase the action of plasmin, and plasmin's role is to cut and break down fibrin that's in the mesh of the clot itself. So we have a couple of different options. Most of them are just recombinant versions of things that we normally find in the body. So the first one that you guys would have been given is TPA, tissue plasminogen activator. And as we learned about earlier, antithrombin 3's job is to activate TPA, which then converts plasminogen into plasmin, which then breaks down fibrin. So we thought, well, why not just take TPA and give it to someone? And so we have two different forms. We have alteplase, and we have tenecteplase. Oh, there's another one too, but I can't remember it. I can't remember. I think it is an R. I don't remember. What I will tell you is that there's another TPA one. I can't remember what it is. Tenecteplase is a longer half-life. That's really the only difference. Oh, Retivase. Yeah, that's it. Retivase. So the first kind of thrombolytics that we have are the TPA. The other one is using a different enzyme called urokinase, which urokinase, instead of activating the conversion of plasminogen to plasmin, directly does the job. So urokinase is the second thrombolytic that we can give. So our two thrombolytics are pretty good at what they do, I'd say. I don't think they I don't think they the biggest thing to know about them is that one, they're recombinant, so you have to give them in a hospital setting. They work really, really, really well, which means that you have to be careful with someone who is receiving those drugs because you don't want to um, accidentally make them bleed out, because that would be very, very, very bad. Trying to think if there's another one. I don't think so. So really, all you have to know about the thrombolytics is that we have the first category is TPA derived, which is your alteplase, your retivase, and your tenecteplase, where these guys are just longer acting. And then the other one is your urokinase derived, and they kind of do their thing. The last category of drugs that we're going to use are fibrinolytics. So lytic means to cut. Fibrin means fibrin. So our fibrinolytics are the ones that break down fibrin, which is all of these guys up here, right? Where we care about the anti portion is where we have bleeding disorders. So these are conditions where someone is already at risk of bleeding. So clearly, if someone is already at risk of bleeding, we don't want to give them a drug that is going to cause them to bleed, right? So the goal here is to use drugs that will inhibit that process. And so the two drugs that are used is examic acid. I think that's how you spell it. And then the other one is aminocaproic acid. And really what these drugs are doing is that in our diagram here, they're coming in and they are sticking to plasminogen. And what they're doing is that they are preventing the conversion of plasminogen into plasmin. So what their role is to prevent the breakdown of fibrin. They do not work anywhere in the coagulation cascade. So if you get a question about, which coagulation factor does tranexamic acid work on, none of them. It does not work on any of the coagulation factors. It only works on plasminogen.
Wait, so so does that mean that tranexamic acid is it also used for bleeding?
Um, it wouldn't necessarily be used in like hemorrhage where someone is like has a gastric ulcer or something like that. The reason is because it works too slow. So in a case where someone is bleeding too much, we wouldn't necessarily use it like that. We use it in bleeding disorders, things like von Willebrand disease. Uh, I think it's used in hemophilia. These are conditions where people are having microbleeds across the body. And so, in order to inhibit those microbleeds, we're using tranexamic acid or the aminocaproic acid. The danger, though, is what happens if you use these drugs? What's the potential outcome that can come from antifibrinolytics? If you inhibit the clot breakdown,
Oh,
you
isn't it just you can develop a thrombus?
exactly. So someone could be at risk of stroke, right? So if you're going to be making it easier to clot, then you're going to make it easier to clot, which means that they might get ischemic, they might have a heart attack, they might have a stroke, lots and lots of different stuff. But the the goal here is to balance the bleeding disorder with the clotting ability of the drug and end up somewhere in the middle. Um, that sort of thing. Any questions about any of those drugs that we talked about?
So just going back on the anti-fibrinogen, yeah, it's just in class you just call them hemostatic, and you
Oh,
said they.
same thing. Yeah,
Okay.
hemostatic drugs, same thing.
Okay. And it's just going back. I just want to go back on the pathway, the one that you drew, the one that you broke down, and yeah, that one. So the anti-fibrinogen, they just like you said, the tranexamic acid only works in on fibrinogen, right? It doesn't work nowhere else but fibrinogen.
On plasminogen
Yeah.
down here, not fibrinogen,
Okay.
plasminogen. But yes. So aminocaproic acid, tranexamic acid, they both work on plasminogen. Um, they and the goal there is to increase clotting in a way.
Okay. And then going back on the thrombolytic, these are for you said five. No, I don't want to say. No, I don't want to say something like confusing. But you said these work only for like TPA,
Yeah,
right?
they're essentially synthetic versions of TPA. So where antithrombin 3 comes in, it works directly on the cascade, but it also works to create plasmin, which breaks
Mhm.
down the fibrin clot. So we
Right?
can just give synthetic versions of TPA instead of giving like synthetic antithrombin, for example.
Got it. And then for warfarin. So it prevents it prevents vitamin K from being recycled, right? From being reoxidized.
Exactly. Yep.
Okay. Okay. All right. Okay.
All right. All right. Let us go back to all the way back to arachidonic acid. So just to review where we were, previously when we talked about arachidonic acid metabolism, we talked about how arachidonic acid is metabolized through the COX enzymes, enabling us to create thromboxane and then all of our prostaglandins. We had originally talked about it in terms of the aspirin, which is an irreversible COX-1 and COX-2 inhibitor, and how inhibiting COX-1 prevents the creation of thromboxane, which is antiplatelet. And as you get to higher and higher doses of aspirin, you start to get more COX-2 inhibition, and that's what creates all the anti-fever, analgesia effects of aspirin. What we have going on is we have tons and tons of other drugs in the body that work on the other COX enzyme. All right. So we can talk about the NSAIDs very broadly because for all intents and purposes, they act the same way. So the NSAIDs are a group of drugs that are reversible COX-1 and 2 inhibitors. So unlike aspirin, which is irreversible, the NSAIDs are a reversible process, meaning that we decrease prostaglandin synthesis. The big outcome of having this COX-1 and COX-2 inhibition is essentially it plays a major role in where we find the COX enzyme, is the way that I want to explain it. Whoops. So, COX-1 is found in all tissues. The predominant type that we find is really, in terms of where we care about, is the gastric mucosa and renal cells. COX-2, however, is found only in the cells that are, well, it's found mainly in the brain, the kidneys, and cells of high inflammation. What I mean by that is that when you have inflammation, it leads to a increase in COX-2 expression. So what this means is that over time, as COX-2, as you have a finger you smashed in a car door, that's going to cause a lot of inflammation. And so as those cells continue to say, we're damaged, we're damaged, we're damaged, they start to produce more and more COX enzyme. What we can say is that depending on where you have your different COX enzymes, you get different effects. For example, there we go. In uh in the stomach, in the gastric mucosa, the predominant prostaglandin that's produced is PGE2. And we talked about this a little bit before, but the role of PGE2 is to decrease acid production and increase mucus secretion. The other factor in kind of general or the other ability of PGE2 is to cause general vasodilation, which is what's going to lead to that inflammation around the body. So, what is mediating your finger to swell up after you smashed it in the car door? Well, that would be PGE2. Oop, I put that in the wrong section. Of course I did. Of course I did. So I meant to put that here. PGE2, vasodilation, inflammation. The other effect that we see throughout, kind of generally through the different prostaglandins that are produced, especially through PGE2, in the brain, we have an increase in thermo in an increase in body temperature. This is also a local effect as well, which is why if you hurt your finger, it might start to feel hot. And then also, too, we have nerve sensitization at the site of injury. So Cox is involved in the ability to sense pain and then how painful that process is. So with this in mind, we can now see just what the effects of using the NSAIDs are. So by inhibiting COX-1, what this is going to do is lead to a decrease in PGE2, specifically in the gastric mucosa, in the stomach, we'll just say. That's where the largest effect. Is this very beneficial? Not at all, because the effect of having this COX-1 inhibition is that we get peptic ulcers and potentially GI bleeding. So great, our drug is already causing issues. In terms of COX-1 and 2 in the kidney, by decreasing PGE2 and by decreasing PGI2 in the kidney, we get two major effects. The first effect is that we end up having afferent arterial vasodilation. The second effect is that we get an increase in sodium retention, which increase in sodium retention. One second. I just want to make sure I'm saying this right. Whoop. Yes, increase in sodium and increase in water retention. This should be vasoconstriction, though. So we have two major effects. One is we have afferent vasoconstriction, and the other is that we have sodium and water retention. What this means is that the vasoconstriction is creating an unbalanced change in filtration, and so we end up getting a decrease in GFR. So the kidney is performing worse. And then on top of that, we're increasing our blood volume, which is going to raise blood pressure. It's going to increase the risk of edema. So in people who need to be on a fluid restriction, such as people with heart failure, which is not good. And then it creates the increases the risk of AKI because we're changing the filtration capacity of the kidney, as well as it being directly toxic. So far, we have had no benefit, right? None at all. When we look at the decreasing the effects of COX-1 and 2, I think it would be COX-1 and no, COX-2. There we go. Decrease in PGE2 in inflamed damaged tissue. this is where we start to see the beneficial effects. The first is that we get some general general decrease in vasodilation, which is going to decrease the swelling in the area. Likewise, we're going to decrease the body temperature, which is going to act as an antipyretic. And then decreasing nerve sensitization, which is going to be our analgesia that we are looking for. Da, da, da. Yes, I think we can. But do we? Oh, and then kind of as an aside as well, in our platelets, of course, we're going to be decreasing thromboxane, which means increasing bleeding. Can't forget about that.
And all of that are the side effects for NSAIDs, right?
Yeah, this is where we get the side effect profile for NSAIDs.
Oh, so I had a question actually about COX-2.
Mhm.
Since celecoxib is um since celecoxib is a COX-2 inhibitor specific, does that mean it only has the effect of at the bottom, vasodilation, decrease in body temp, nerve sense, and then will there be some of the effect in the kidney or just the effect at the bottom?
It's selective for COX-2, so it doesn't have any effect really on COX-1. There
Okay.
is something to say about COX-2 though, and this is something important that we should mention.
Okay.
By decreasing the action of COX-2, which again, this can be, all NSAIDs, which are the majority of them are non-selective, and then celecoxib is COX-2 selective. One of the effects that we see is in how do I want to put this? By decreasing PGI2 in the vasculature, one of the big effects that we see is that this actually increases platelet aggregation. And the risk of this is, of course, that we have an increased risk of stroke and MI. What's interesting to note about this effect, though, is that in terms of which, for whatever reason, this effect is lowest in obviously aspirin, right? Because we know aspirin is working as an antiplatelet, but also in naproxen. And if I remember correctly, I think it's because naproxen is almost like it's a COX-1 selective. It has some COX-2 activity, so it is technically non-selective, but I think it works primarily on COX-1, which is why we don't really worry about naproxen and this risk of stroke with it. Don't You'll have to fact check me on that one though. So this is where we start to get the side effect profile and the uses of NSAIDs, right? And we can group them based on, which enzyme we're affecting. Are you affecting COX-1? Is it COX-1 and 2, or just COX-2 alone? The other important thing to know is that not all NSAIDs are created equal. Some of them are much more powerful than other ones. Other ones are just directly toxic to the different tissues that they work in. For example, the ibuprofen and ketorolac, which let me grab a image. There we go. Ibuprofen and ketorolac are acids. They have a carboxylic acid moiety in them already. Now, a lot of our NSAIDs have them specifically. And if you look at a lot of the different structures, which when we go through MedChem, we'll take a look at that more specifically, a lot of them have carboxylic acids, but specifically ibuprofen and ketorolac are pretty potent, pretty acidic drugs. And so ibuprofen and ketorolac are really, really bad in terms of like GI ulcers and stuff like that. Can really mess people up. Not good. All right. Last part that we're going to talk about with NSAIDs is taking a look at the and in asthma. So we talked about this in terms of, on the first day, we talked about the arachidonic acid metabolism. And what I just want to briefly talk about is that when we use NSAIDs or aspirin, we have to be careful with people who have very, very severe, very reactive asthma. The reason is that if you were to use an NSAID, so if you used an NSAID or aspirin, what's going to happen is that you're going to cut off half of arachidonic acid's ability to be metabolized, right? Which means that more arachidonic acid is going to be shunted through the 5-lipoxygenase pathway, and you are going to increase leukotriene production. Leukotrienes are associated with asthma exacerbation. So is this in everyone? Will they, suddenly their asthma is going to be much, much worse if they, take an ibuprofen? No. But it can be for someone who has severe, severe, severe asthma, they probably want to stay away from NSAIDs. because it's just going to make that process so much worse. All right. That was the last thing I wanted to talk about with NSAIDs. What else is on this exam?
Everything from the beginning.
Oh, right. Well, we'll go over that more specifically on the weekend. But is there any group of like new drugs on here?
Let me see. Oh, the glucocorticoids, but we haven't gone over those yet.
He hasn't done them in class.
Yeah, he only has tomorrow, and I don't know. And I think I'll cover those tomorrow.
Yep. All right. Then we'll go through them right now as well. All right. Let me just bring up my notes. Forget where we talked about them. I'll just talk generally, and I'll probably hit the right stuff. Let me just bring up a diagram for myself. Mm, All right. Glucocorticoids. Glucocorticoids are a group of drugs that have a wide range of effects. Huge range of effects. Um, I imagine he only really wants you to know about the like anti-inflammation effect, which is I don't think he wants to go into like immunosuppressive or endocrine effects yet. So that's primarily where we're going to focus on. But what I actually I think I have did I download it? Oh, I think I did. Let me bring up the packet real quick. Uh, can you hear my bird in the background moaning
Yeah.
because he wants attention?
Wait, which one was it? Was it Bactrim?
It's Spectrum. Yeah,
It's always Bactrim.
it's always Spectrum. Oh, okay. So it is only the anti-inflammatory effect. Mm-mm-mm. All right. So, oh, he wants to be on my shoulder. All right. Here you go, buddy. Glucocorticoids are the why is he talking about mineralocorticoids? He's only talking about okay. All right. I think I see what he's doing. You'll have to tell me essentially what's going on. When we look at glucocorticoids, we can actually take a look at them in terms of how they factor into the arachidonic acid metabolism. We talked about how before we even get to arachidonic acid, we have the all right, buddy, you gotta be quiet if you're gonna be right behind me. Can't have you just moaning in the background.
Maybe he's hungry.
I think he's tired and he wants me to go to bed.
Oh, he's like your own little cockadoodle, sleep reminder.
Pretty much. All right. If you remember, in order to get to arachidonic acid, we have to use the enzyme phospholipase A, which cleaves certain lipids off of the inner side of the membrane, allowing us to make the arachidonic acid. Where glucocorticoids come in is in two different places. The first is that glucocorticoids have a direct inhibition on phospholipase A. So they are preventing the production of arachidonic acid specifically by working on the precursor enzyme. Essentially what this is going to do is you're going to get massive anti-inflammatory properties, right? Not only are you inhibiting the prostaglandins and the thromboxane, but you are also going to be inhibiting the leukotrienes. So you are shutting down the inflammatory process across the entire body, which is what makes the glucocorticoids so powerful in terms of their ability as anti-inflammatories, because they're working everywhere in the body and they're working on every pro-inflammatory molecule there is. One of the other is that IKB? Yes. One of the other transcription factors that we didn't necessarily talk about was this thing called NF-κB. Essentially, what NF-κB is that it's a transcription factor needed to enhance the production of the COX-2 enzyme. So what this means is that when those cells that are damaged detect that there is, you slammed your finger in a car door, they're using NF-κB as a way of telling the nucleus, hey, we need to make more COX enzyme. What glucocorticoids are doing as well is that they are working on NF-κB and decreasing the expression of the COX-2 enzyme. So even though that we are affecting the metabolism and the creation of arachidonic acid, which is all, well and good, that's going to take some time. What we can do in the short term is we can prevent the current COX enzymes from increasing in levels by inhibiting their expression. The overall effect of glucocorticoids is that what we see with them is just a general anti-inflammatory property. What's interesting about them, and let's see, I don't know if he's going to talk about these other things. It doesn't make sense for him to talk about these other issues. I'm not going to go into it. I'm not going to go into like the effect on the immune system because he'll talk about that later next semester.
And also, I don't know if you can see the slides, but he also talks about hold on. He also talks about like the glucocorticoid receptors and the mineralocorticoid receptor and the
Yeah,
HP axis, whatever that means.
what I think that's more of just to set up what they are. I don't think he's going to spend a lot of time talking about it. I think it's really on that slide 18, really where he's going to spend most of the time. I'm just looking at because he didn't talk about glucocorticoids, but just in terms of like where this is fitting into the lesson, especially with NSAIDs and stuff like that. Um, that's really where I wanted to demystify what he's going to talk about with slide 18, which essentially slide 18 is just expressing what these two little lines right here are talking about. That glucocorticoids decrease phospholipase A by connecting to the glucocorticoid receptor, and then they decrease the NFKB expression through the glucocorticoid receptor as well. What I will talk about, and this is something that is a little bit confusing, and it took me some time to kind of figure out. We talk about the release of cortisol. So glucocorticoids have a complex system in terms of how they are regulated in the body through something called the HPA axis. Essentially, the way that it works is that we have the hypothalamus, which is like the great thermostat in the body, and it detects, oh, we have major inflammation going on in the body. Maybe we should release some glucocorticoids in order to prevent that. So it releases something called corticotropin releasing hormone. Releasing factor, my bad. And this works directly on the pituitary gland. And the pituitary gland is like a big factory whose job is to create adrenocorticotropic hormone. This is going to work on the adrenal cortex, who's finally going to release our glucocorticoids and our mineralocorticoids. And that's essentially what the HPA axis is that you get this connection between these three different glands. Now, in the body, our glucocorticoid is cortisol, and our mineralocorticoid is aldosterone. So what is acting as our anti-inflammatory molecule through the HPA axis is cortisol. The other name for cortisol is hydrocortisone. When the body makes the molecule, it is called cortisol. When we make the molecule, it's called hydrocortisone. They're the same thing. They're exactly the same thing. The difference is we use a different name depending on where it comes from. Hydrocortisone comes from us in a lab. Cortisol comes from our adrenal cortex. So what ends up happening is that once the body releases some of the cortisol, it then uses feedback inhibition to turn off the HPA axis. This negative feedback is really important because, as we saw, glucocorticoids have a wide range of effects. So if we didn't turn off the HPA axis, then we keep releasing cortisol, and eventually, once we get to high enough doses, we turn off the immune system, and then all of a sudden we're ready to be attacked by some bacteria that normally wouldn't kill us. Sorry, I just sneezed. What's important to know here is the dosing timeline of when we give a glucocorticoid. And essentially, what we care about, and I'm recreating the graph that's the last slide in the packet on slide 19, is that let's say that someone has asthma, and we're going to give them prednisone in order to get rid of their asthma attack. So we have day 1, day 2, day 3, day 4, day 5, day 6, day 7, day 8, day 9, and day 10. $11, $12, $13, $14. So what we can measure is the amount of glucocorticoid that's in the body. On a normal day, you would have a normal amount of glucocorticoid, right? So here it is, floating around the body doing its thing. What ends up happening, so this is your endogenous glucocorticoids. What ends up happening is that, let's say that on day 2, I give the patient exogenous glucocorticoid. What this is going to do is it's going to turn off the HPA axis because it's going to start going through this negative feedback. So instead of the endogenous cortisol that's being produced, I'm now taking exogenous prednisone and sticking it into the system. And what that's going to do is it's going to shut off the internal production of cortisol, right? So let's say for the next I don't know, 7 days, our person is going to be on prednisone. So is the amount of prednisone that we're going to give them going to change at all? No. They're always going to end up with the same amount of prednisone. Why? Because it's in a pill. Because we're constantly suppressing the HPA axis with this exogenous glucocorticoid, we start to see a rapid fall in the amount of glucocorticoid that the body is producing, to the point where after a few days of taking it, after about 5 days of being on, a pretty moderate dose of prednisone, you are no longer making your own glucocorticoid, right? So what this means is that if on day 9 this person finishes their course of prednisone, is their cortisol levels going to jump right back up to what they were normally, within 24 hours? No. And in fact, it's going to lag behind by a couple of days. So what this means is that someone now doesn't have the ability to regulate inflammation in their body, or they don't have the ability to regulate epinephrine and norepinephrine, or they don't have the ability to regulate their immune system, or their kidney is all fucked up now. And so what ends up happening is that during this lag time, we can put someone into a crisis where their endogenous levels are too low, and we didn't enable for there to be enough time for their levels to come back up over the course of a couple of days. Is that kind of sort of making sense so far?
Yeah. So I think without tapering, their level of glucocorticoid would rise back up on the 12th day.
Yeah, about a couple of days after they would have stopped their prednisone, for example. So let's take a look at what a taper does. 7, 8, 9, 10, 11, 12, 13, 14. So same sort of situation on, days 0, 1, and 2, they're making their normal amount. But now instead, day 2, we give them their prednisone amount. Day 3, they get the first 3 days, they get the, high doses of prednisone. And then we start to taper off the amount of prednisone that they're getting. So something like this. What this means is that we're going to drop their cortisol levels quickly. But as the taper starts to happen, we're enabling for the rise in endogenous cortisol levels, meaning that by the time that someone stops taking their prednisone, their cortisol levels that they are naturally making should come back to normal. And that's really what the thinking behind the tapering is. So what is what is the danger of having this, days where you don't, is essentially you are creating something called adrenal insufficiency. So it's a situation where you've turned off the adrenal gland, meaning that you don't have the ability for the body to regulate um, the the essentially, you know, all of the processes in the body: temperature, immune system, inflammation, vasodilation, and constriction. Tons and tons and tons of different things are um, uh, glucose regulation is a huge one with glucocorticoids. So by not having any uh by having just these couple of days, you can put someone at real risk of death, really, by allowing them to just kind of exist like this. Hopefully that makes sense. This is I've never explained this before, but hopefully that kind of came out coherent in a way.
No, it makes sense though. It makes sense. So if you suddenly stop, the body will just the body won't be able to just adjust to the sudden start like sudden like start so to the sudden yeah, it wouldn't just adjust, and it would take a couple of days for the body to just restart making its own pretty much, right?
Exactly. Yep.
Okay.
Yep. 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 All right. Um. All right. I think that's everything. The new stuff for PCOL. So tomorrow, not tomorrow. What's today? Thursday. Um. What day do you have MedChem? Tuesday?
Okay, we have medcam Thursday.
Thursday? Oh, okay. Then we won't. All right.
PCOL is Tuesday.
Is Tuesday?
Yeah.
Oh, okay. All right. So then we'll do MedChem on Saturday. Then we'll do 2 days of PCOL probably. Um, or depending on what people want to do. And then we will take a look at Thera and we'll have a grand old time. It'll be lots and lots of fun. All right. I will see you this weekend.
All right, thank you, Gabe. Wait, Saturday will be 7 to 10, right?
Yes. Yep. I might also be in person on Saturday.
Okay.
I'll still, have it virtual as well. Like that will
Yeah,
always be a thing. But if you're going to be around this weekend on campus, come on by.
I
We'll
bet.
we'll do that. All right, sweet. I will see you this weekend.
See you.